Before we start today's episode, I would like to quickly read you our podcast disclaimer. The content in this podcast is for general reference and educational purposes only. It is not meant to be complete or exhaustive or to be applicable to any specific individual's medical condition. No information provided in this podcast constitutes medical advice and is not an attempt to practice medicine or to provide specific medical advice, diagnosis, or treatment. This podcast does not create a physician-patient relationship and is not a substitute for professional medical advice, diagnosis, or treatment. Please do not rely on this podcast for emergency medical treatment. Remember that everyone is different, so make sure you consult your own healthcare professional before seeking any new treatment and before you alter, suspend, or initiate a new change in your routine. Welcome to The Starting Gate. We're your hosts, Dr. Kitty Donaldson
and Dr. Sarah Sheets,
two internal medicine doctors who spent years practicing traditional primary care. Over time, we realized something was missing from modern healthcare. A real understanding of how everyday lifestyle choices impact overall health.
We'll help you cut through the noise of the countless health influencers and their conflicting opinions, because no matter who you follow, the basics of lifestyle medicine are at the heart of it all.
Welcome back to The Starting Gate. We're your hosts, Dr. Kitty Donaldson
and Dr. Sarah Sheets.
Well, hopefully you did well with last week's challenge of trying to incorporate more of those NEAT activities. So that was trying to incorporate non-exercise activities. So you were trying to stand and walk when maybe you would normally be sitting. And hopefully you're seeing how those little extra bits of movement really make a big difference in your day.
And today we're going to continue talking about cardiovascular health with a focus on hypertension, otherwise known as high blood pressure. It's a very important topic because about half of the population in America deals with hypertension. We've touched briefly on high blood pressure with Dr. Cotter, but today we have another local expert in the field, Dr. Katie Donaldson. She is a nephrologist at the University of Kentucky. Dr. Donaldson, can you tell us about yourself?
Sure. I'm originally from Northern Kentucky, and I have been in Lexington since 2011, went to medical school residency and fellowship here, and I am a general nephrologist at the University of Kentucky, and I also have a dedicated hypertension clinic there.
I think when most people think of hypertension, they think of cardiology. Can you tell people what in the world a nephrologist, a kidney specialist, has to do with high blood pressure?
Sure. So the kidney is one of the major organs kind of associated with it. There is a hormonal axis known as the RAS system, which the kidney helps to regulate. And in addition, there are associated types of hypertension, renovascular hypertension, that can be mediated by the kidney. So cardiology is very involved, but nephrology also has a part in that as well.
And I know we're focusing mostly on cardiovascular health, but could you just give a small little snippet of how high blood pressure can impact your kidneys?
Sure. Over time, it can actually be one of the major causes of chronic kidney disease. Actually, diabetes and hypertension are like 75% of the cases collectively of chronic kidney disease. And so if going unchecked can lead to a point where you see progressive decline in renal function. So it's very important to maintain good blood pressure for kidneys.
And can you start by just telling us a little bit about what is blood pressure, what is systolic blood pressure, which is that top number, what is diastolic blood pressure, the bottom number?
Sure. The systolic blood pressure, that top number, happens when the heart contracts, whereas the diastolic blood pressure is when the heart is at rest, kind of in a filling phase. So you get kind of a value of the top number being your systolic blood pressure over diastolic. Generally, they say roughly 120 over 80 is normal. Classification of hypertension for most recent guidelines is above 130 over 80.
And does one matter more than the other? Is that top number more important or the bottom or what?
So the top number is more important, and it's because of the associated cardiovascular risk with elevations, and that high numbers, resistant hypertension, can increase risk for things like heart attack, stroke, kidney disease, for example.
So to clarify the definition of high blood pressure, we're going to break them down into different categories. So to reiterate, a normal blood pressure is 120 over 80 or less. If you have a systolic blood pressure, that's the top number, of 120 to 129, that is considered elevated blood pressure. Stage 1 hypertension is 130 to 139 on the top, or 80 to 89 on the bottom for a diastolic blood pressure. And then stage 2 hypertension is readings of 140 over 90 or higher. So that gives you a breakdown of each of those buckets. And your doctor's going to give you different advice based off of what bucket you fall into, as well as what other risk factors you may have. Some people who have diabetes, kidney disease, or a higher risk of stroke or heart attack, your doctor may want to be more aggressive at lower numbers than someone who doesn't have those risk factors. So this is really a personalized approach on when you would need to be adding medicine versus working just on lifestyle or needing a combination of both.
Blood pressure basically above 130/80 increases risk for cardiovascular problems. As far as severity of hypertension, when patients get up to like 160s or higher, that's where we really get into concerns for things. And if patients, for example, get placed on blood pressure medications and in spite of those things cannot achieve adequate goal, then we start looking into potentially secondary causes. So not just what we would deem central primary hypertension, but trying to make sure that there's nothing else that's underlying it.
And that brings up a great point, because I do think that sometimes we don't really understand that there's other causes for high blood pressure. Many times people believe they either genetically have high blood pressure or they don't, but it's way more complicated than that, I think is what Dr. Donaldson's trying to say. And with that being said, what are some of those chronic conditions that can put you at an elevated risk for high blood pressure that may be more challenging to control?
Sure. Things such as like obesity can put you at higher risk. Sleep apnea can put you at higher risk. And then when you get into the resistance category, some of the things that we try to look at are hormonal issues, things like primary hyperaldosteronism. We check for things like hypercortisolism, and then things like renal artery stenosis, which can elevate blood pressure.
And so somebody might worry about that if they were really young and found to have blood pressure, or when should somebody think, maybe that's me, that I have another reason to have high blood pressure?
Definitely, if you're young with elevations in blood pressure, usually we'll look into secondary causes, but also, by definition, resistant high blood pressure being 3 medications, one of which is a diuretic, so a water pill, if those patients are not achieving goal, or if they're on 4 or more medications and maybe have gotten controlled, may suggest some type of resistance, which would warrant further workup.
And I think sometimes this doesn't happen for many patients. And that's specifically what you do in your clinic, correct?
That's correct, yeah.
And what about, is there a level where blood pressure can be too low?
I would say depending on how the patient feels with symptoms. So not necessarily a certain threshold, but if the patient is feeling like they're going to pass out. And then sometimes what you'll see with patients who've had persistent blood pressure is once you get them to goal, and if you do that quickly, you might see that they actually don't feel as well either. But I would say that looking at it, not necessarily a specific range so much as it is if the patient is feeling symptomatic as a result of where their blood pressures are.
So if you're somebody out there running around with a blood pressure at 91/56, but you feel good, you don't need to worry about it. But if you're somebody that's normally a blood pressure of 145/80, and now you've suddenly come down to 91/56, you're probably going to feel that, in which case that might be a little low for you.
Correct, yes.
Everyone likes to check their blood pressure here and there, and many patients will check it at home, even from the recommendations of their doctors or just because they're curious. Is there specific guidelines to do that well that you recommend to patients?
Absolutely. The AHA has a beautiful diagram of someone sitting, getting their blood pressure taken. So recommend an arm cuff at the level of the heart with the patient having rolled up their sleeve, sitting for 5 minutes with their feet flat on the floor, back against the chair, and then making sure that they've emptied their bladder prior to this. In addition to that, making sure that the blood pressure cuff size is correct, that it's not too big or too small, which could make the readings less accurate. Those procedures are something that I advocate a lot in my clinic.
Is there a certain time of day that is ideal, or is a mix better?
I usually do a mix. It kind of depends on how the patient is explaining kind of their blood pressure. Particularly in my resistant clinics, sometimes they'll have kind of like a peak blood pressure. Most of the time, for a lot of patients, it'll be kind of in the morning. However, some patients tend to increase at nighttime. And so I usually try to get kind of a feel to make sure that the blood pressure is kind of consistent through the day.
How do you feel about the wrist cuffs?
They're not my favorite. If the patient does it, advocate for it held kind of at the line of the heart. Really what I like to do if that is the case is just to make sure that the measurements are kind of consistent and making sure that, home readings are very different than what we would achieve in clinic. Sometimes for some patients that's kind of what we have. Some of the blood pressure cuffs that you can buy, they can get quite expensive. And so the importance of kind of taking a consistency of measurements and then trying to ensure that the validity of those measurements.
Yeah, I had a lot of people that would come in, or they would tell me that their blood pressure at home was really high. And when I would check it in the office manually, it would be okay. It would be normal. And so a lot of times I'd have them just bring their cuff into the office and we would check it with their cuff and then check it manually. I would check it and there might be a 20, 30 point difference. What do you tell people where their cuff is measuring different than the doctor's office?
If it's something that's reproducible, we just kind of keep note of that. But most of the time I ask them to replace the cuff if possible. Let's just say if there is discrepancy of measurements, there's a lot of data to suggest that home blood pressure readings kind of over time are better than the in-office because you don't have the white coat hypertension effect, things like that. But yeah, for the patients who do have the discordant blood pressures, usually try to replace the cuff.
And can you explain what is white coat hypertension? Because I imagine many of our listeners have heard those words before, but maybe don't really understand what it is.
Sure. White coat hypertension is when patients come to the office and their blood pressure is significantly more elevated than it would be at home. And for those patients, presuming that their blood pressure trends are the normal range, sometimes you may overtreat them in certain circumstances. There's also a phenomenon called masked hypertension. They come to the office and have relatively normal blood pressures but are hypertensive on the outside, but they're a very small percentage of the population with blood pressure. I have a lot of my patients follow with checking blood pressures at home to help with titration of their medicines.
And something else that's very common when people start checking their blood pressure at home, say they check it at home and it is high and they're like, is that real? Is that not real? What is your recommendation on the recheck? Like, do you check the other arm? How long should you wait? Should you do it later in the day? What is that advice? Because I know that comes up a lot.
Usually I'd say within 1 to 2 minutes of rechecking, presuming that, they've kind of been seated for a time, just to see about if this is just kind of like a one-off measurement. Sometimes I will check to make sure that both sides are reading at the same, but I usually have them check within a minute. And some people will do a few repeat checks as well during that interval. And then really you still may have kind of a one-off measurement that's elevated, but as far as making sure that everything is kind of consistent and that the patient isn't symptomatic from having those high blood pressures, having things like headaches, chest pain, shortness of breath, things like that.
So if somebody does check and they're higher than usual, let's say they're normally in the 135/80 range, and now they've checked and they're 165/88, but they still feel fine, feel normal, no symptoms. Can that person just try to relax, check it again later?
Yes.
What should that person do?
So exactly that, actually. Yeah, so kind of relax, and sometimes I'll tell them to kind of check it within an hour, kind of sometime a little bit later, because you will see sometimes that fluctuation and could just be a one-off measurement.
And that might be a good time to practice your mindfulness or gratitude or meditation to help just kind of bring that down.
I have been known in the office for people who have white coat hypertension to play some music. Let's relax for a little bit. Let's do some breathing exercises. And then let's recheck, because it makes a difference for many, many people, because I feel like some are just more responsive, and getting their blood pressure checked is a very stressful thing. Some people get stressed out going to the dentist. Some people get stressed out getting their blood pressure checked. And, we have to accept that and try to make the environment as calm as possible, because I think that can make a difference in your readings.
Does insurance cover blood pressure monitors for people that have a diagnosis of hypertension, or for someone that doesn't want to shell out a lot of money?
Some do, yes. There is a form. I have the privilege of having pharmacists work with me in clinic, and she usually helps me kind of fill that out, but I don't believe it's universal. And admittedly, I don't know which insurances would cover.
Yeah. So maybe worth checking.
Yes, correct.
And I've seen some of the newer cuffs, they do 3 readings in a row and kind of give you an average. Is that,
yeah,
do you feel like that's the best bet if someone's really looking for the best cuff.
I definitely think that's helpful. The brand that I typically recommend is like an Omron. They have various kinds of cuffs, the ones that kind of like automatically inflate. There's a few from like Welsh Allen, but for some patients, cost is a factor. It's kind of, as long as we can kind of have something that gives accurate blood pressure measurements, that's fine. But yes, as far as like the 3 readings, that's great. I don't often see that. So
yeah, maybe we'll find one of these and put it in our show notes, put a link to one of the ones that Dr. Donaldson thinks is a good lower cost, but good, pretty reliable blood pressure cuff. So on the thought of things that might be causing that one-off, either higher or lower read when you're checking it at home, what are some things you see do that for people?
I feel like a lot is kind of maybe stress-related, to your point, as far as having like anxiety kind of taking with blood pressure. I do see that sometimes. Sometimes you'll have patients notice that they'll have kind of like periods of higher blood pressure, which actually could be associated. They'll say, I've been eating a lot more salt in my diet, and sometimes you can definitely see a change.
Well, let's stop on that salt topic because Sarah and I love that one.
Since you're speaking of salt, we'll just stop right there and tackle that one. Can you explain to listeners about salt and how it impacts blood pressure and the idea of salt-sensitive individuals and not salt-sensitive individuals and how it can be a major player in people's blood pressure?
Absolutely. So kind of the more salt in the diet can inflate blood pressure. So typically for most guidelines, it's recommended to stay kind of under 2 grams. And you will have some patients who may be less sensitive, as you say, where it may not have as much of an effect. But there are some, and particularly in patients with like resistant hypertension, you can see sometimes very significant inflations in blood pressure related to that. And so generally advocate to try to reduce salt in the diet, reduce how much you're eating fast food wise. Had a mentor at one point in time, this is a terrible way to say it, it's like, if it tastes good, spit it out. But to the point of going to restaurants and things like that, is that it usually is laden with salt as far as like the flavoring goes. So, kind of on another topic, there is some association and kind of in the kidney world with increases in like potassium diet and improvement in blood pressure. I can't usually see it in my patient population because I'm usually discouraging that. And then you put patients on medications that can inflate potassium. So I personally don't necessarily, but it is something that when you do read about dietary-wise to potentially do it, particularly focusing on foods that are kind of rich in that, bananas, avocados, tomatoes, theoretically could have benefit.
Yes, and I think that's what the DASH diet is all about, and is one of the most studied diets when it comes to improving your blood pressure with lifestyle. And its emphasis is doing both of those things, reducing sodium and then increasing your fruits and vegetables that's going to bring up that potassium, and eating more whole foods that will reduce the sodium as well, and can have a huge impact in many people's blood pressure. And I will say that I have watched in many of my patients that have focused on this have dramatic improvement in their blood pressure just by dietary changes.
That's incredible.
Yeah.
Yeah. And so if you are someone that's on a lot of blood pressure medicines, maybe talk to your doctor about it if you're going to be making a big change and increasing your potassium a lot. But especially if you're someone that maybe you're getting on the verge and you're thinking, oh, high blood pressure medicines are in my future, this could be a good place to start to see if you could delay that.
Absolutely.
Down the road.
And one little caveat there is that doesn't mean that you're going to take potassium supplements.
No.
So we're just making
Would
sure.
highly discourage that.
We discourage that. It is something that if you're not taking blood pressure medicines, as Dr. Donaldson said, many blood pressure medicines are causing your potassium to rise. So once you're on medicine, you don't get as much as the same impact by eating more potassium. But for those of you who may not be on medicine yet and are on the verge or just trying to get better control, increasing those foods higher in potassium can make a difference, but we want it to come from our food.
And what about things like, I feel like I see a really big trend of people taking electrolyte drinks or putting those packs in their bottles of water. Is that something you feel like people need if they are, let's say, exercising on a regular basis? Do they need to replace that sodium with these drinks?
I don't usually advocate for it, no. Kind of goes back down to just, kind of trying to just eat healthy and then drinking water.
Because I know when it comes to electrolyte drinks now, there's such a wide spectrum. I feel like we used to have just a couple of options, and now they are just have imploded, and there's just so many of them. And there are some that have up to 1 gram of sodium in them. I think the biggest thing for listeners is paying attention to that and noticing, am I drinking 3 of these a day and suddenly I'm having 3 grams of sodium in my water? That would be of major concern.
How about things like coffee or Red Bull or other energy drinks? How do those affect blood pressure?
So there is an association with caffeine, in particular with inflation in blood pressure. It's usually in pretty large amounts. So as far as if you have blood pressure issues already and are drinking a lot of that, you may see more robust changes in your blood pressure.
And then what about exercise and its impact on blood pressure?
Particularly with aerobic exercise, that can decrease blood pressure by several points, and so is recommended.
And I see some people checking their blood pressure at the gym.
Yeah.
Right after you finish exercising, you're still sweating, catching your breath. That's probably not the best time for you to be checking.
Remember Dr. Donaldson advice, you need to be sitting, relaxing for at least 5 minutes.
That's right. So definitely don't check your blood pressure. And if I do have patients who do check it and are like, oh, this was after, just kind of committing to that advice, yes.
So don't think that exercise is raising your blood pressure in the long term. It may raise it temporarily afterwards as you've been active, but it's going to help over the long run to bring it down. Are there any dietary supplements or vitamins or things you see people taking lately that seem to have a negative impact on blood pressure?
Well, I'd say the one thing that people don't think about is actually like pseudoephedrine. When you have a cold, Sudafed can inflate blood pressure. One thing that I have seen, maybe like the GLP-1s that have led to improvement in obesity, I haven't seen robust changes, but there is like a theoretical benefit depending on kind of the weight loss aspect of it.
I'm glad you brought up the pseudoephedrine, actually, because we are in cold and flu season.
Yes.
So I think a lot of people are buying decongestants. Is there one in particular that you recommend for someone that does have high blood pressure that's the safest option?
Usually you have to take out the D components, so it does decrease kind of like the efficacy and the relief that people get. They can take things like Mucinex, but Mucinex D or just like regular Sudafed would not necessarily be recommended, unfortunately.
Yeah. So if it's got the -D, that's probably going to make you feel better. Correct. It's probably going to raise your blood pressure, so stay away from it.
Well, and the other thing, and especially kind of from the kidney standpoint, is NSAIDs. Like sometimes you can buy like Advil and that, and both of those medications can also inflate blood pressure. So.
Oh, great point. While you're on that, how does daily use of things like ibuprofen or naproxen, that NSAID family, how can that impact blood pressure? Since you brought that up,
it can kind of inflate blood pressure, and so generally speaking, if that is one of the things that patients are requiring frequently, try to reduce as much as possible.
And I think that's important because many times people think about taking too much ibuprofen can hurt their kidneys, but they may not be making that correlation that it also could be impacting their blood pressure as well.
That's correct. Mm-hmm.
Other lifestyle changes that impact blood pressure, we have to talk about sleep. When we talk about blood pressure, can you go into what does poor sleep do, and then a little bit on sleep apnea?
As far as sleep goes, there is kind of an association with people, for example, who work night shift, having more incidence of like cardiovascular risk as well as hypertension. And then as far as sleep apnea, particularly in the setting of resistant hypertension, can be kind of a contributing factor. And so getting a sleep study, being evaluated for sleep apnea, CPAPs help, but usually patients still require medication. It's not going to be kind of a panacea, so to speak. It's usually like a reduction of about 3 to 7 millimeters mercury.
And we'll have to do a show at some point about sleep and sleep apnea. But in general, if someone tells you that you're gasping for air at night, or you're getting, your 7 hours of sleep at night, but you're still nodding off every time you sit down to read a book, those might be clues to you that you need to investigate for sleep apnea.
I usually ask patients about like whether they're snoring, and then talk about kind of like their daytime sleepiness. Like if they're getting sleep but not feeling rested is kind of a big indicator that something like that could be happening.
Now, when we start talking about patients that have done all the things, have tried lifestyle changes, and they still have high blood pressure in those patients when they've done everything correctly, is there a genetic component that is playing into those patients? Because I know some people feel very defeated despite doing all the things, and they're like, Doc, I still, it's not budging. Why is that?
With patients who have a history of hypertension, there are, I guess, maybe some genetic predisposition to having elevations in blood pressure. But sometimes kind of the way that I tell patients is that we can try to optimize things as best they can. And, that's excellent with kind of all of those factors. But then sometimes, even in spite of everything, you still just need kind of a medicine to help you. And that's not, to be a fight that's been lost so much as it is just kind of an inevitability of having hypertension. I've had some patients who actually get treatment for, maybe a secondary cause that's underlying it, but they still have essential hypertension. And so it may be something that helps to treat blood pressure, but not necessarily cure the fact. It cures maybe kind of the process that you're seeking, but not necessarily the hypertension as a whole. And I know it can be very frustrating, but, if you're doing everything else, it's just kind of the next step, so to speak.
And I think one of the things I always try to reiterate is, if you need one medicine, you doing all these lifestyle factors are helping you decrease the dose or the fact that you might need two if you weren't doing those. So don't feel like all your efforts are lost because they're still making an impact in general. But sometimes, medicine is needed. And when we talk about medicine, how should we think about taking blood pressure medicine and its importance? Sometimes it gets very confusing. If you take your blood pressure every day, you're like, do I need it today? Do I not need it today? And it can be a little bit of a roller coaster. How do you explain compliance when you come to talking about blood pressure medicine?
Sure. The importance is very substantial in the essence that you're trying to prevent complications of having hypertension. So kind of your heart diseases, your kidney diseases, et cetera. For some patients who may achieve good number on medicine, just kind of reminding them that the medication is in fact working. And, sometimes compliance with medication can be very difficult. So I try to encourage patients to find ways in their daily routine that can help them know when to take medicine. So, if that's brushing your teeth at night and keeping your medications like that, some people do well with pill boxes. My dad has one at home and my mom sets it out for the week. Or I have some patients, they're like, I know that I'm going to go to work for most days of the week and they will keep it in a little vial on their keychain or what have you because they're like, oh, when I pick it up, I remember that I'm going to take it. So whatever works in their schedule such that they can remember to take it.
So what Dr. Donaldson is explaining is habit stacking, which I love. So finding a habit that you already have and just taking your pills to that habit so it becomes a habit in its own. So I love that because it does make it much easier when you make it a part of your regular routine so you can remember it better.
That's right.
Toothbrush, coffee maker, whatever you need to do to remember to take it. And I think one thing I just want to stress, which she said, is you are not determining each day whether or not you take it based on your blood pressure reading that morning. I had a lot of patients maybe be nervous because their blood pressure was looking pretty good in the morning, and then they thought, well, maybe I shouldn't take my blood pressure medicine. Maybe that would make it too low. But the blood pressure medicine is working. It's helping keep it that way. So keep going. Take your blood pressure medicine every day. Don't base it on what your blood pressure value is if you check it.
That's right.
And what about taking your blood pressure medicines at night versus in the morning? Is one better than the other?
Yeah, a lot of people have a blood pressure surge in the morning, so I will generally recommend that. Usually I tell them in the morning. However, some patients will say that they feel a little bit more fatigued. There is some research to say that taking blood pressure medications at night may be helpful from a cardiovascular standpoint. There's a phenomenon where the blood pressure declines as patients sleep called dipping. Generally, you'll see a 10 to 20% decrease, and sometimes either in patients who don't have that and or who take blood pressure medications at night, it helps them kind of from a cardiovascular standpoint as a result of that. So I would say typically I say in the morning, but depending on how the patient feels or depending on sometimes maybe the medication and sometimes, to facilitate compliance if patients are like, I know I'm not going to do it in the morning because I'm going to work. I had to take my kid to daycare. I had to, shuffle things. So in those circumstances, kind of finding a time, and if it's better at nighttime, that's fine too.
And one of the big ones that probably we would avoid at night are water pills or diuretics.
That's correct.
Nobody wants to get up and have to use the bathroom.
When are we doing that at night? No. What about if, let's say, somebody normally takes their blood pressure medicine in the morning and they get to 3 o'clock in the afternoon that day and they go, oh my gosh, I forgot to take my blood pressure medicine this morning. What should that person do?
I think it depends on the medicine. So, for example, things that are usually dosed once a day, like lisinopril, things like that, I usually would say it's okay to kind of take. For some things, for example, I have some patients who take hydralazine that's frequently dosed 3 times daily. If it's closer to that afternoon dose, what I would say is just skip that morning. Same with beta blockers, so to avoid kind of a stacking effect of that medication. Taking something that's closer to, it'd be basically double the dose. I think depending on the medication, that sometimes I would advocate for them to take it. Other times, just kind of skipping it and letting it go.
So I think in summary, that's a great question if you are starting a blood pressure medicine to talk to your doctor about, just so you already know. There's many times we are going to forget medicines, right? And knowing what to do already can be very helpful. So if you're starting a new medicine with your doctor, just asking, hey, what do you recommend? In the case that I forget a dose, what should I do? Just so you already have that knowledge.
Yeah, the better prepared you can be for all the scenarios with your medicines and how they interact and things, the better off you're going to be down the road. What about when blood pressure gets really high? When should people be worried?
Specifically when they have symptoms, so things like headache, visual changes, chest pain, shortness of breath. And then really, if blood pressure is high and then it's consistency of measurements, definitely go see your doctor. But if you're having kind of those symptoms, sometimes I'll have to send patients directly just to the ER to make sure. Then you get into what we call hypertensive urgency emergency, where basically the blood pressure has to be lowered in a controlled fashion to prevent overcorrection, but also to ensure that the patient isn't having any adverse side effects of the high blood pressure itself.
Yeah, so if you are getting a high blood pressure read, let's say you checked your blood pressure because you were feeling headache, vision was seeming different, and you checked your blood pressure at home and it was high, that's a time where you need to go to the emergency room. But you may have times like when you go to the dentist. I felt like I always get a call at least once a week from a dentist.
I get so many dentist calls.
I think everyone their blood pressure just shoots through the roof when they go to the dentist. So if you're going to the dentist and you're not having any symptoms and your blood pressure is high, is that something we should worry about?
I think it's probably just a representative of like a white coat hypertension kind of thing, and definitely stressful. I'd come in with a drill or,
When we talk about the long-term effect of blood pressure, because I think so many people focus on those moments of maybe of the high blood pressure in an exact moment and that's detrimental. But really, a lot of times we're trying to focus on blood pressure management for those long-term effects. What are we trying to really prevent?
So when we talk about, sometimes they'll say end organ damage, you talk about things like left ventricular hypertrophy because the heart is pumping against such a high pressure. You actually start to see it kind of build up like you would anticipate like a bodybuilder. You can have hypertensive retinopathy, which can lead to blindness. You can get, as we could talk about, kind of chronic kidney disease up until a point if it's super resistant hypertension. Patients go on dialysis as a result of that. And then the other things that you'll hear, heart disease may have a higher predilection for CAD and stroke. And then in patients who, to kind of go back down to kind of like the hypertensive emergency, there are various types of syndromes. One that used to be called PRES, posterior reversible encephalopathy syndrome, where patients present with potentially visual problems, maybe some type of confusion, all related to blood pressure. And those things can be significant.
And so if you are someone that has high blood pressure, but it's not exceedingly high or causing you any symptoms, your doctor may be checking certain things to look for these signs of end organ damage. So if you're wondering, why is my doctor checking these labs, making me do a urinalysis, making me do an EKG, those are kind of all ways for us to check. Is there any sign of that heart muscle getting too thick? Is there any sign of the kidneys feeling the strain from this high blood pressure? So there's various things that your doctor may check as they watch your blood pressure over time.
As well as if you're on blood pressure medicines, there are additional labs that may need to be checked based off of the side effects of the medicine. So many times when you're dealing with high blood pressure and on medications, frequent visits with your doctor is indicated, and you should keep those appointments.
Yes.
Even if you think you're doing well.
That's exactly right.
Sometimes I think people also let's say they've been on a blood pressure medicine for the last 20, 30 years. Their blood pressure has done well on the medicine. They may think that they don't have hypertension anymore. Yeah. Can you comment on that?
As far as what I tend to just kind of coach patients on is that the blood pressure medications are working. I can give you an example of this. So my dad stopped his blood pressure medication because he was doing well, thinking that that his blood pressure had gotten better, but really it was the effect of the medication. And it was shortly before he actually had a heart attack with a 4-vessel cabbage. So it's one of those things that consistency is really important. And there are times where I see patients who've been on blood pressure medications for some time, and you start seeing enough change in blood pressure where you can talk about maybe scaling back, and that may happen. And that's also something to kind of chat with your doctor about, is particularly if you're checking blood pressures regularly, noticing a change or are symptoms related to said change, but definitely consistently taking the medication, because the fact that you see improvement means that you're doing good with it. So.
Yeah, I know when I've had patients working on lifestyle changes and have had that positive impact, really wanting to do a slow wean off instead of just dramatically dropping it off one day, because that can be bad.
That's right.
So you want to really make sure that you're ready to come off completely before just taking some readings at home and stopping it yourself.
Yeah.
Definitely talk to your doctor about it. But there are times where, if you have made significant lifestyle changes or you've lost a significant amount of weight,
Absolutely.
where you might be able to come off. So those are
absolutely. Yeah, that's right. So
possibilities. Well, any other just general advice for people as far as preventing high blood pressure or living with high blood pressure healthily that you have for our listeners today?
Just kind of taking medications consistently and then following up with your doctor to address any changes, to follow labs. And then again, things like regular exercise, low salt diet are very helpful in helping to hopefully reduce the burden maybe of your blood pressure medication, as well as to help maintain well-controlled, stable blood pressure.
Well, that's great. You've given us a lot of good information on blood pressure. And so keeping going with what Dr. Donaldson was recommending as far as watching our sodium and realizing how much of that comes in pre-prepared foods, we have our challenge for you this week, which is going to be to try for at least one meal a day of unprocessed or minimally processed foods that you make at home. And just get used to seeing what that feels like to have a meal of whole foods and what that tastes like and how that might taste different from a restaurant prepared meal.
I always tell patients that if you are trying to cut back on sodium, and maybe you are someone who's had a lot of sodium in your diet, if you give yourself about 30 days, about a month, your taste buds do change and it starts to taste better, but you got to hang in there. So if 1 week you're like, oh my gosh, this is tough, keep trying this challenge for another couple weeks, and it does get easier as your taste buds do adapt to less salt.
Yeah, and we talked about this in our nutrition episode, part 1 from a couple of months ago. So we talked about how to decrease the sodium in your diet, probably more than you ever wanted to know. So if you want to hear a little bit more about that, go back to that episode. Otherwise, Sarah and I will be back next week to talk a little bit more about cardiovascular health. We're going to go into a little more depth on cholesterol and some of the other more detailed testing that you might be hearing about on social media and how to decide if that's something worth doing for you or not.
And if you like today's show, be sure to follow us, share the show. And if you have any ideas for future shows, just feel free to send us a text by clicking the link or contact us at contact@thestartinggatepodcast.com.
See you next week.